Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, our monthly television program about the events, people, and happenings here at Southampton, your community hospital. Today we're doing a program about one of our newest services at the hospital, palliative care medicine, and we've invited two very special people, Dr. Daniel VanArsdale, who is Medical Director of Palliative Care Program, Board Certified in Palliative Care Program, and also the Director of our Family Practice Residency Program. So we keep Dan very busy and actually sees patients in between all of that as well. And Amy Reich. Amy is a registered nurse and the coordinator of our palliative care programs here at the hospital, and a resident, I believe, of Montauk, right,
Correct.
Amy? Right. And Dan's out in East Quogue, so we've got both ends of the South Fork covered. And thank you both for being here. Before we get started, though, I'd just like to hear a little bit about each of you and your background and how you found your way to Southampton Hospital. Why don't we start with you, Amy?
Sure. I found my way to Southampton Hospital via New York City.
Okay.
I went to nursing school in Philadelphia, worked in New York City in pediatrics, oncology, and pediatric critical care. And when I moved eastward, I started working in hospice. I segued from oncology to wanting to be in the home care setting.
Okay.
And see patients at end of life. And that led me to the palliative care program at Southampton, because at times hospice was just a bit too narrow and people were often entering those services very, very, very late, where they really could have benefited with earlier intervention of multifaceted support services. So I took a step into a broader range of care, into palliative care, and it's been really wonderful to be a part of the community here.
Well, that's wonderful. And you've been with us, I think, about 2 years at this point?
About a year and a half.
Year and a half, okay,
Right.
Great. Well, welcome, and
Thank
very,
you.
very happy to have you here. And Dr. VanArsdale, let's hear a little bit about you also, and how you ended up here. And I know you have a fairly extensive educational background also.
Yes, so I started practice actually in New York City as well, and in a federally qualified health clinic, and then slowly made my way out east, first to Old Westbury, where I worked at the medical school and taught at the medical school for about 5 years.
That's right.
And it was there that I actually met Dr. Sean Cannon, who's our Director of Medical Education, Chief Academic Officer.
That's right.
And he recruited me out here to start the social medicine training programs that we have here at Southampton. And part of one of the things that we wanted to bring here was palliative care, end-of-life care, supportive medicine, and so we started those programs here, and here we are today, and we're just going to be launching our community-based palliative care program August 1st, which will be a program for the community here on the East End to help folks who want care delivered at home for symptoms, and so that's how I kind of landed here. So a lot of things happening here.
That's
Very
terrific.
exciting.
I know our residency program, well, just a brief aside, is I think we're up to 70, 80 residents at this point, right?
Yeah,
So
about 76 residents.
Right, all training, and
Yes.
a number of them are family practice residents, and the goal is train them here and keep them here, hopefully.
Correct.
Exactly
Correct.
right, which we've done a good job with. Thank you for all you're doing with that. So let's talk about palliative medicine, and the first question I really have, what is palliative medicine? Very new, a lot of ancient concepts actually, I understand, but the whole terminology in healthcare and hospitals in particular is pretty new. And would one of you just answer palliative medicine? Amy, are you?
Sure.
What is it, palliative medicine?
If I had to summarize palliative medicine, because there is so much involved, I would say that it's that you hit the nail on the head by saying there's some ancient concepts. It's what we really should be doing all the time. I think it's the way that medicine should happen, and I think that it's the way that medicine started, and over time we got away from the whole person and started to get into segments and specialties and pieces, and that maybe people forgot that there was a whole person made up of all those pieces and parts. And so palliative care tries to return a little bit of that comprehensive, holistic, whole person-centered care.
Great. And what about, we hear we've known about hospice care and hospice, and we have a wonderful hospice out here in the East End Hospice, which we work very closely with. What is the difference between palliative care and hospice care? People frequently hear palliative care and think, oh, I'm dying. What is the difference between the two?
So, palliative care, when we are called to see a patient on palliative care, we're being called to help that patient through the physical, the emotional, and the spiritual aspects of their disease. And they are seeking a cure at the same time that they're receiving palliative care services. So palliative care is really about addressing the needs of the person and the symptoms they're having while they're seeking a cure.
Okay.
Hospice is really when the patient is no longer seeking a cure,
right,
and is not seeking treatment, but is receiving comfort measures, so addressing their symptoms so they don't have pain, they don't have nausea, things like this, where palliative care really starts and should begin at diagnosis. So when a patient is diagnosed with a serious illness or a chronic illness, that's really when palliative care should be initiated to help them through the myriad of questions that they have. What's going to happen to me? How does this turn out? And then deal with symptoms as they develop, which tends not to be the focus of people who don't understand or aren't specialists in palliative care medicine.
Right.
They're focused on the disease and treating the disease. And as Amy said, palliative care really looks at the person, how the disease is impacting the person. As I said before, physical, emotional, and spiritual aspects of that.
So I'm hearing two sort of concepts that I think are important. One is that stepping out, not just looking at the disease and really looking at the whole person and everything else going on with the person, levels of comfort and distress, stress, pain, all of the things associated. And hospice sounds like a key differentiator is certainly end of life, whereas palliative care isn't necessarily end of life.
Correct.
Okay.
By virtue of having any chronic illness, there is, we believe, inherently a need for extra support, whether it's nutrition, symptoms that may arise from treatments or from the disease itself, spiritual issues that a person may wrestle with, and disruption to family life. Financial issues are often a focus, and people are frequently in and out of hospitals even with the best controlled care. So they really need that increased support from a team of people.
Okay. And well, that was going to be my next question. So who provides the palliative care?
It's a team.
Okay.
It's a team. It's a physician, it's a nurse, it's a social worker, it's a chaplain, and then there are ancillary services that the palliative care team and program provide. Everything from alternative approaches to care like massage, acupuncture, osteopathic manipulative medicine, Reiki. Pet therapy, and the goal...
Pet therapy, too.
Yeah,
I know we have that. I didn't realize that was offered for palliative care also. So.
And really the idea from all of it is to support the person, alleviate some of the fears that surround serious illnesses and alleviate physical symptoms.
Okay.
And that really takes a team to do that.
And someone may be being treated, as you said, by their own doctor, whether a cardiologist or a surgeon. What is the palliative care physician doing that's different from the actual physician, and how are they communicating during that process?
So, there is communication between the primary care physician and the palliative care team or the specialists that are dealing with them, and while their primary care physician or whatever specialist is looking at the disease process, we're bringing up and managing, as Amy said, the effects of the treatment or the symptoms that the patient may be having that don't necessarily get communicated to the specialist or to the PCP.
Okay.
Their focus is more on how is this disease progressing or not progressing, and we're more focused on how the disease is affecting the person,
Okay.
and how to ameliorate those issues. And so that's the communication that we have with the primary care doctor or the specialist that's involved with that patient's care.
I see. And I understand that it's a medical subspecialty at this point, or specialty. You yourself are board certified, Dr. VanArsdale, as a palliative care doctor?
Yes, we have 5 board certified physicians here in our community in hospice palliative care medicine. It does require a fellowship training. Okay. That's a year-long program, and we actually have a training program here.
After another residency?
After a primary care training. And we have a fellowship training program here at Southampton Hospital. It's a year-long program. Okay. And that program certifies you to sit for the boards in hospice palliative care medicine. Okay. Are there any specialties in nursing or other professions?
I hold a certification that's called Certified Hospice and Palliative Nurse, and similar, it does not require the fellowship that a physician specialty would, but you require a certain number of hours and experience to be eligible to sit for the certification exam. So my training in hospice and oncology and critical care gave me the hours to be able to then sit for the board exam and hold that certification.
And a similar question for you, Amy, a palliative care nurse. How what you're doing as a palliative care nurse is different from a regular nurse on the floors in the hospital?
Sure, and it's a great question also because a lot of what we do is sometimes very subtly behind the scenes, so the pieces of the plan of care together. We could definitely not do it alone as a team without the primary team and other consultative services, the nurses and aides at the bedside. And I think that we add something extra to them, that we bring something different. So palliative care nursing is different from what a registered nurse might do on a regular shift because we have more time to sit, make a relationship with a patient and their family, discuss the goals of their care while they're in the hospital and often beyond the hospital. We are communicating with each of the teams to make sure that the communication loop is crucial in the care while they're here. So we are coordinating a lot of the communication pieces between the different teams, between the social workers, the case managers, the nursing supervisors, the nursing managers. So it requires a lot of communication. And I think it requires an insight into understanding how the bedside nursing is taking place, as well as what the patient might need beyond what that nurse at the bedside is doing. Just for instance, the medications that they might receive, knowing that a particular medication may be causing a patient nausea or causing them to experience constipation, that somebody just forgot to look, wear an extra set of eyes and ears. And reminding people in the hustle bustle that there's actually things we can do sometimes to prevent. So we do a lot of anticipatory guidance with the patients. We do a lot of education with the patient and family. And we do a lot of support with the family, especially as they're preparing for discharge to their next step.
I see. So what sorts of illnesses would be good candidates, or what's I don't know that that's the right question, or what kind of patients would be the right kind of candidates for palliative care? Are there specific kinds of conditions or patients that particularly would benefit?
So any disease that causes suffering is a disease that would be appropriate for palliative care.
Don't most diseases cause suffering?
Correct.
Okay.
Correct.
Right.
So any disease that causes any kind of suffering. Right. And it's different for different people. But that's the basic thing. Okay. So it could be anything from congestive heart failure, obviously cancers are what most people will think about, but it could be COPD or emphysema, any disease that causes suffering.
What if it was something that wasn't chronic? I came in for appendicitis and I was in particular distress, or I had a bad break that required hospitalization to set a fracture for a period of time. Can palliative care be involved in those kind of conditions as well?
It can, but generally that's not. Generally,
Right.
it's more of a chronic disease
Okay.
that has an ongoing issue and that will require ongoing treatment.
Okay.
So anything that most things, most acute issues do not require palliative care.
Right.
But any issue that will require ongoing treatment
Okay.
requires it. That is where palliative care is most appropriate.
I see.
And I think the differentiation there that may be important is that although it's true, any reason for hospitalization, any illness, any surgery or injury will certainly cause some suffering. And
Right.
nobody wants anybody to go through suffering, and everybody understands that it's upsetting and very difficult to go through a hospitalization. So that palliative philosophy, that way of looking at the person could certainly benefit in that case. But the expectation with most of those acute issues is that the patient will return to the baseline from which they entered the hospital.
Okay.
So somebody with a fracture, they should repair it and most cases not suffer complications
Right.
and can return to work, return to family life, whereas a chronic disease is bound to be disabling. Even when it's managed well, it will cause more upset to the life of
I
the person.
see. Something they'll be living with and struggling with, and give them the tools and resources to help them. When would a patient, I guess the question is, can a patient request palliative care, or does it have to be ordered? Typically, we don't do things unless it's ordered by a physician. How does that work, and when would a patient know to ask for palliative care?
Patients can request,
Absolutely.
and many of them do, who know that the service is available.
Right.
Or sometimes families will request palliative care
Okay.
from either their experience here at Southampton, or if they were admitted to another hospital where they received those services. They will request palliative care. Obviously, a physician, whoever the primary care physician is for that patient, can also request a palliative care consult from the team. And those are the two ways that we get patients
Okay.
in the hospital.
Okay.
Yep.
And what sort of symptoms can people really expect relief from? What are the things, and is it? It doesn't sound like it's curing so much, but it's relief from the suffering. I'm still grasping with that concept a little bit. So what can a patient expect?
Sure. We say that our typical symptom cluster is nausea, vomiting, diarrhea, constipation, pain, and
Okay.
shortness of breath, any kind of difficulty breathing.
Okay.
Of course, there could be other symptoms beyond that. Those are the ones that are most common and that we assess for at initial consultation and then reassess for daily and sometimes more than one time a day. And the aim is, of course, to prevent when possible that symptom, or if not able to anticipate it, then to relieve it when it happens. But there can be other ways, certainly other things that might cause suffering, that might be something that we could relieve. For instance, somebody who is accustomed to going to some kind of daily mass or a daily spiritual, we can certainly arrange for communion to be given to a patient while in the hospital, or to call in a clergy or some kind of spiritual support person for beyond our own chaplain who visits them daily to come into the hospital.
Well,
So
that was
that
going
might
to
be
be
suffering.
a follow-up question, actually. It sounds like it's not just about doctors and nurses. You mentioned the team as a number of other people. And could you just review again who's on our team here at Southampton Hospital?
Sure. At our hospital, I'm the nursing coordinator,
Right.
Dr. VanArsdale, his wife, Dr. Allison VanArsdale, Dr. Laura Siska, who's a Meeting House Lane physician,
Okay.
and Dr. Howard Sklarick are the physician team members. Dr. Maria Sika just recently completed her fellowship. She was the first fellow to train here,
Okay.
and had a lot of experience prior to coming to the hospital as a primary care physician.
Okay.
Loretta Dahlia is our massage therapist. She has been indispensable to the team because she really comes in without an agenda, as so many of us clinicians do come in with an agenda at times. And there's one particular patient that I'm thinking of recently who she actually didn't want pain medication. She didn't want a lot of the services that we offered. She only wanted Loretta. That was the umbrella. Her services of massage and Reiki were the relief that she needed for her her cancer suffering. That was the only thing she wanted. And so Loretta was the most important team member in that case. We also have Mary Hogarty, who is a chaplain. She's a certified hospital chaplain, which requires a lot of education.
Yeah, it sure does.
And then we have a social worker named Lori Sims, who also does a lot of specific training to be able to handle the complexity of patients.
Okay.
So those are the core team members, and then as Dr. VanArsdale mentioned, certainly we draw in, we kind of oversee the pet therapy program.
Right.
We work closely with case managers, we work closely with a lot of the nursing and physician staff throughout the hospital.
So
We
a lot,
also-
oh, I'm sorry.
We also have 2 certified acupuncturists
Yes.
who will see hospitalized
Acupuncturists
patients.
in the hospital?
In the
Yes.
hospital.
Okay, great.
And we have a neuromuscular skeletal team
Okay.
that will also come. That's a physician-led team. It's a hands-on form of medicine. It's very
Right.
gentle, and that can relieve a lot of pain and help with the healing process in patients who are admitted to Southampton.
Right.
And so that kind of, I think, rounds out what the services that we have.
Tremendous number of benefits beyond just prescribing and the typical sorts of things we would see in a hospital. And you mentioned pain and pain medications, and hot topic these days with all the opioid issues in our society, and the opioid addiction rates very high. Is pain management still with medication still a part of the program? Is it still something that we look at? And I guess what's the view? How do pain medications fit into palliative care? Obviously, and
It's a big part of palliative care, relieving physical pain, and so full spectrum of approaches.
Right.
Everything from IV drips for pain medication
Right.
to oral meds to, and in some cases, we'll consult anesthesia to put in pumps and things like that to
Okay.
relieve pain for people.
Okay.
And the other thing, we have a chaplain who also helps us address kind of existential suffering and pain related to end-of-life issues or
Right.
fears of dying, or what does it mean to their family, things like this. And so, so we also have the full spectrum, because pain, all pain is emotional and physical.
Right.
And so the team addresses those issues as well.
And with the pain management, I think the education for the nursing and physician staff, many of the residents are learning. They haven't been exposed to palliative care in medical school. It's just as important to educate the staff as well as the patient and family about the appropriate way to manage pain, and that may be, as Dr. VanArsdale said, a combination of chaplaincy, complementary therapies like acupuncture or massage, in addition to prescribed opioids or non-opioid medications.
Yeah.
And so it's important that pain is done appropriately, and that the staff understands the way to do it appropriately and what's inappropriate.
Seems like we're really adding to the toolbox of mechanisms or ways to deal with pain other than just medications, which certainly, given where we've been in society lately, sounds like certainly a good thing to me. That's for sure. You mentioned the family members. Let's talk about that a little bit, and what do we do to support the family members, and how can a family benefit from the palliative care program?
So we will have family meetings with the family members of the patient, and it's really the meetings are we're a sounding board for the family, for them to listen to their fears, their concerns, help them understand what's happening to their loved one. I think many times they will hear what they believe is contradictory information, where a specialist will come in and say, oh, this part of their body is fine, and then another specialist will come in and say, well, that part of your body is not fine. And so they feel like they're getting contradictory information, when really it just needs to be kind of brought together and those pieces of information put together into a coherent picture,
Right.
so that they have a fuller understanding. And so we meet with families to help do that, and that relieves a lot of angst and suffering that the family may have. And then we talk about what they would want for their loved ones, particularly if their loved ones can't speak for themselves,
Right.
and help them through a decision-making process or begin a thought process about how they're going to handle issues that will arise with their loved one through the course of their disease. And so it brings a lot of peace to the family, even during difficult times, at least to have a team of people that help them develop a plan, tell them it's okay,
Right.
and work out issues, because certain family members will have different ideas about what should or should not be done. And so we're a sounding board and a forum for those discussions.
Often a struggle in hospitals with family members who, different dynamics in different families, and people reacting differently to a sick parent or child or spouse, and clearly brings out a lot of stress in families. So I'm glad to hear we're providing that support. And you mentioned social work and other sort of practical services. Can you give me some examples of those kind of services that we're providing as well? So.
Sure. I think to reiterate again what we said, sometimes in the team dynamic, sometimes the social worker is the most important member of the team in that particular case. Sometimes the chaplain is the most important person.
Right.
Sometimes it's the massage therapist. So it really depends on what a family and the patient needs at a given time. So a social worker might do things like contact the Women's Coalition for Cancers, which provides community resources for a patient with gynecologic related cancers when they go home. She might be responsible for arranging those home services like physical therapy, coming to our wellness center for free massages, getting supplies paid for or subsidized in some way. They often are they're the go-to person for insurance questions, so they're often helping people with an application process to Medicaid, perhaps.
Those forms are horrendous.
Which is very daunting,
Right,
Right.
right.
So that requires a lot of support, and it's very time-consuming. And sometimes we approach a family when you know what the goal might be, but the family really needs the step-by-step process to get themselves there. They might need help making appointments. They
Right.
might need help understanding the language, that they're not medical people. So it's a lot of education and patience and support.
I know, having once had a very sick father, family members get very stressed out and worried. Am I doing everything correctly? Are there things I'm forgetting? And sometimes we just don't even hear what the people in the hospital are telling us. So I guess providing that ongoing support's got to be very, very important to many people.
There's also a very important member of our team that, beyond the inpatient services that we do, there's a social worker who provides bereavement services to patients who may die in the hospital, may die after being discharged from the hospital, or may not have even been a patient here on palliative care service or in our hospital. They have the option to attend a bereavement group that's hosted by a certified clinical social worker.
That's amazing. And one of the things I picked up on that you mentioned earlier, Dr. VanArsdale, was this notion of bringing the services to the home. And how are we going to do that? How will that work?
Well, it's going to be a team approach. We've partnered with Dominican Sisters. And so people who are out in the community who would like palliative care services can call and request them. And that will trigger the team going to visit them in their home. The Dominican Sisters, our partnership with them will also be identifying patients who may benefit from what palliative care offers, and then patients who are here in the hospital who palliative care sees in the hospital as a patient, will offer to continue those services when they're discharged. To provide that needed support that many patients don't get when they're initially discharged home, and so that's how we're going to do that through our partnerships with Dominican Sisters, and also they can contact the palliative care office here at the hospital and request those services.
It sounds fantastic, and I can't emphasize enough how grateful we are to both of you and the entire team, frankly. I know that we're Joint Commission certified, one of the few programs actually in the state that's Joint Commission certified for palliative care, and I recently received a letter from a family member whose brother passed away, actually, and they could not have been, it was a very emotional and very heartfelt letter, and they talked about you specifically, Dr. VanArsdale, how you even sat with the patient and dealt with a lot of sort of end-of-life questions for them, and I think that was an amazing, it seems like we're kind of bringing the caring back to healthcare. It seems like a big part of what we're all about. So I'd love to ask you more questions, but unfortunately we're out of time, and thank you again, both of you, for the great work that you're doing for the people that we serve here. And if any of you would like to receive additional information both about palliative care for your loved one, yourself, while in the hospital, or our new home-based program that we're developing, our coordinator nurse, Amy Reich, is available, and she can be reached here at the hospital. Just call our number at 631-726-3200, and we will get your questions answered. I'd like to thank all of you for tuning in today. I'd like to thank our friends at CTV for the great work they do in producing and airing this show in Southampton. And as always, our friends at LTV for airing the show in East Hampton. If you have any questions, concerns about healthcare, an idea for a future program, or just need help navigating the healthcare system here on the East End, as always, please feel free to call my office at 631-726-8555. Thank you, everyone, and good health.